Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS learning that you can fit into your busy life. I'm Dawn Liz Powell, Medical Editor at MIMS Learning. Today, I'm talking to Dr Chris Arden about the diagnosis and management of atrial fibrillation in primary care. Chris is a GP near Winchester and he also works in community cardiac clinics in Southampton and Winchester as a GP with a specialist interest in cardiology. Welcome to the podcast, Chris.
Thank you very much, Dawn.
Thinking about atrial fibrillation, we know it's a fairly common presentation in primary care. Roughly, how many people are diagnosed with AF in the UK each year?
That's a very good question, and there's a school of thought that we're probably under-diagnosing at the moment for a variety of reasons, because a lot of people with atrial fibrillation may well be asymptomatic, so we're picking them up opportunistically. But looking at the national data, the incidence rate is about 1 to 2%, which equates to roughly 250,000 new cases of atrial fibrillation a year. And the prevalence is roughly between 1.4 and 1.6 million patients with atrial fibrillation.
So that's like quite a large group of people, but they won't all have the same type of AF. So what are the different types of AF?
There's essentially three types of atrial fibrillation. The first is paroxysmal atrial fibrillation, which by its nature tends to occur intermittently, usually reverts to sinus rhythm within 48 hours and certainly within 7 days, and doesn't need any intervention in terms of restoring sinus rhythm. So the symptoms of paroxysmal come and go, and patients can often be relatively symptomatic during these episodes. The second classification is patients with persistent atrial fibrillation, and these patients have atrial fibrillation that lasts longer than 7 days. And in order to restore sinus rhythm, we need to intervene either pharmacologically with medication to antiarrhythmic medication, or more commonly with electrical cardioversion. The third group of patients are those with permanent atrial fibrillation. And in this group of patients, the atrial fibrillation is the accepted long-term rhythm. And the focus in this group is really making sure that their symptoms are well controlled, because that manifests in terms of their quality of life, and also managing their stroke prevention, so looking at thromboprophylaxis, which actually applies to all three groups as well.
In terms of risk factor, I'm guessing that age is a risk factor.
Age is probably the single most strongest risk factor, particularly patients over 65. The incidence and prevalence significantly increases in patients over 75. So in this group of patients, due to demographics and patients living longer, that's another driver why we're seeing a lot more atrial fibrillation than we were a generation ago. The other issue is a lot of these patients are living with comorbidities which provide the substrate for atrial fibrillation, such as hypertension, living longer with coronary artery disease, heart failure, diabetes, and cardiometabolic conditions, and sleep apnea, which are risk factors for developing atrial fibrillation. There are also acute precipitants for atrial fibrillation, such as infection and thyrotoxicosis, major surgery, particularly cardiothoracic, and alcohol intoxication that for some people who've got an underlying substrate can be enough to trigger atrial fibrillation.
What about coffee if you drink too much of it? Are you concerned at all about any drinks?
Good point. I mean, coffee I'd probably be less worried about. I think there's lots of other stimulant drinks and products out there which have a sort of adrenergic, catecholamine-like effect. So for those individuals who may have an underlying susceptibility or substrate for atrial fibrillation, that may well be enough just to trigger it. The commonest thing we see in our practice, both in the community, cardiology clinics, hospital, and working in general practice, is alcohol. So I think it's always worthwhile just exploring the individual alcohol history, whether that's chronic intake over a long period of time or short, more intense period of binging. Sort of alcohol, again, for some people can be quite a potent trigger. So that's probably the most common cause. But absolutely, drugs and medication, particularly illicit, so thinking about other sort of stimulants that individuals might be taking, it's worthwhile exploring that in the history, particularly if you're looking at rhythm control strategies. So you're looking to get them back into sinus rhythm because of the impact the symptoms are having on their quality of life. And you want to give them every chance of maintaining sinus rhythm once that's been established. We need to remove any potential drivers for recurrence of their atrial fibrillation. And particularly for younger patients, that can be around lifestyle factors, and alcohol is probably the most important of those. As well as weight, so obesity, again, is a risk factor, sleep apnea. So encouraging people to take up some form of activity, sedentary lifestyles, all those sort of things tend to increase the incidence of atrial fibrillation. So anything we can do to correct and address that will reduce the chances of them getting AF in future if we're able to get them back into sinus rhythm.
I'm just going to plug that MIMS Learning has an obesity campaign at the moment called Confidence in Obesity Care. We have a range of modules trying to support healthcare professionals to help people with obesity. So that's called Confidence in Obesity Care. So I'll put the link to the campaign page in the show notes. But back to the interview, you were mentioning before that AF can be difficult to diagnose because it can be asymptomatic.
Absolutely.
It's sometimes not even diagnosed until they've had a stroke. We are going to discuss the risk of stroke later. But what can the GP do to detect AF?
I think we'd need to be far more proactive and more opportunistic. There's a number of studies that were done a few years ago looking at systematic screening, where you effectively screened everyone above a certain age, or you took a more opportunistic approach. And certainly the latter one looks like it would yielded better in terms of the workload that was put in from a clinical perspective. So definitely opportunistic screening, and you can start off with pulse palpation in our chronic disease clinics, so certainly our diabetes clinics, COPD clinic, potentially even in flu clinics where we're in contact with more elderly patients. So pulse palpation is a good technique, and obviously you need to follow that up with an ECG if you do pick up an irregular pulse. These days, obviously, a lot of people have access to different types of watch or monitoring devices. And again, that's yielding quite a lot of what we're, relatively sort of silent or asymptomatic atrial fibrillation. So there's lots of different strategies available, but I think we do need to be more proactive. And undoubtedly, if patients are presenting with symptoms of breathlessness, and sometimes those can be relatively soft, so things like breathlessness or reduced exercise tolerance or just reduced sort of functional status, again, in elderly patients, can be markers. So again, auscultation, pulse palpation, and ECG in that setting can be very helpful and rewarding in terms of detecting atrial fibrillation.
I'm just thinking, so like I'm 45, gone for a health check, 5 years ago now, went for that health check thing, and they take your blood pressure. So is it right that you actually doing a pulse check when taking blood pressure is actually quite important, because because if you are in AF, you won't get a good reading on the blood pressure. So for that reason, you should check the pulse to make sure you're going to get an accurate blood pressure reading?
That's a very good point. Before you do any blood pressure, we should check the pulse, both to detect any arrhythmia or sort of irregular pulse, because you're absolutely right, that'll affect the reading that you get. And if they've got AF, there'll be significant beat-to-beat variability in terms of their blood pressure reading. So yes, absolutely. And if they do have an irregular pulse and they're not known to have atrial fibrillation, then we should follow that up with some form of monitoring, and ideally a good quality 12-lead ECG. And in patients with known AF, we shouldn't be relying on electrical blood pressure cuffs. Really, we should be resorting to the gold standard of doing it manually, just to sort of iron out that sort of variability that you get in atrial fibrillation in the blood pressure readings.
Okay, so when you say manually, do you mean take the pulse manually, or
both? Do that. You can take the pulse manually, but then do the blood pressure manually as well.
Because this is my ignorance, the blood pressure monitor will pick up the pulse as well.
Some of them do. There's one called Watch BP, which is an automated blood pressure monitor, and that's got a sensor in it which picks up an irregular pulse and will highlight that actually on the blood pressure display. So if they've got an irregular pulse, then it'll highlight that. It can just pick up ordinary benign ventricular ectopy, not necessarily always atrial fibrillation. But obviously the only way you can distinguish between the two would be with either a rhythm strip or an ECG. Some blood pressure machines do have that facility and functionality.
Okay, so you sort of mentioned the 12-lead ECG there, and then so NICE say that to confirm the diagnosis of AF, you've got 12-lead ECG, whereas the ESC states that you can use a single-lead ECG. What's your view of single-lead ECGs and their role in the diagnosis of AF?
I certainly favour the ESC view, and I think a good quality 30-second single lead ECG. And the key thing is good quality. Surprisingly, you can see a lot of sort of technical issues and artifact even with the single lead monitors. And one of the ones that many people may be familiar with is the Cardia Alive Core, but a lot of the Apple Watches and similar watches have software that actually can take ECGs as well. So I would go along with, if you get a good quality 30-second ECG single lead tracing, then that from a diagnostic point of view secures the diagnosis. I agree with NICE, you should always follow it up with a 12-lead ECG because you get so much more information from that you won't get just from the single lead. But in terms of detecting arrhythmias, a good quality single lead tracing is acceptable. I mean, I had a case of a patient literally just a couple of weeks, exactly that, who presented with a really good quality sort of cardia tracing. History was very suggestive of paroxysmal atrial fibrillation, and I was very happy to manage it as such.
Okay, so that obviously sounds like a benefit of these sort of Apple Watch and other devices. And obviously, to be very clear, you can get gazillions of devices like that playing that ECG, but only some of them a medical grade one. So that's like a benefit, is that you can, it might help give context to someone coming in, help you diagnose AF. Is it a problem as well that you're going to get people looking at a watch coming in, panicking they've got something wrong with them? They've just drunk too much coffee that day or something?
That's probably more of an issue, is all the concern and worry and all the other sort of benign stuff that these devices and sort of monitors are picking up. And I think it's just a challenge that we face not only in primary care, but in secondary care. There's a lot of data out there. It's navigating through it and trying to make sense of what's actually relevant and what isn't. From a patient's perspective, yes, it can engender a lot of anxiety and concern. And sometimes you obviously just have to follow that up with more sort of medical grade monitoring, whether it's 24-hour, 48-hour patches or other forms of monitoring.
With AF, now obviously, certainly in terms of primary care, the major concern is stroke. And I think you're sort of saying that this is a risk with whatever type of stroke the patient has, but I'm guessing with someone with permanent AF, that is more of a concern. And if they're older and got other risk factors, the risk will depend on what else is going on with that patient.
Absolutely. The guidelines would suggest that whichever of the three forms of atrial fibrillation you have, whether it's paroxysmal, persistent, or permanent atrial fibrillation, their thromboembolic or stroke risk is the same, and that'll be determined by other risk factors and comorbidities. And that leads us on to the scoring systems and the CHADS-VASc that we're all very familiar with now. So depending on which form of AF they have, you'll still make a decision around anticoagulation based on their other risk factors, independent of the form of atrial fibrillation.
Okay, so you just mentioned CHADS-VASc, which is it's heart failure, isn't it? It's age, it's diabetes.
Previous stroke. And CHADS-VASc, yes, includes any sort of coronary disease and obviously female gender in the CHADS-VASc one.
I was going to say about this because the ESC, they've just 2 years ago now that they've changed their guideline and they've dropped female gender from the risk score. What was your feeling about that?
I think it's a good move, and I think in a funny sort of way we've been moving that way anyway. And I think when CHADS-VASc first came out, It was based on good, solid registry observational data that women did have an increased risk of stroke, but it did cause quite a bit of confusion as to whether that's just a risk modifier or actually is an independent risk factor for stroke. And I think over time and more contemporary data since then, particularly registry and cohort data, has actually shown that it's only a risk modifier rather than a risk factor, female gender, and it only becomes relevant if there's an additional risk factor such as hypertension, or they've had a stroke, or they're 65 or above, or 75 or above. So at that point, then female gender becomes more relevant, but as a risk modifier rather than an absolute risk score. And that's essentially what the ESC were recognizing. So they've effectively dropped the female gender from their scoring system. And I suspect in time we'll see that aligning with what we do in the United Kingdom. CHADS-VASc is so well established now in primary care and all our scoring systems around QOF and everything. So there's an issue there that needs unpicking, but I think it's only a question of time before the two align, and we'll see female gender simply being a risk modifier rather than an independent risk factor on its own.
When you're saying risk modifier, basically that would aggravate an existing risk factor.
Yeah. When you start to accrue other risk factors, whether that's age or diabetes or hypertension, then there certainly is, it does modify and probably does enhance that risk. So that's when we either need to be considering anticoagulation or, in the majority of patients, actually offering it because their CHADS-VASc score or the European score is 2. And at that point, we should be offering anticoagulation.
Okay, and so with anticoagulation, obviously, the concern is the risk of bleeding. Which patients are most at risk of bleeding, and how could these risks be mitigated against?
There's some really good scoring systems, and HASBLED is one of them, and NICE actually endorsed one called Orbit. Personally, I prefer the HASBLED scoring system because it looks at sort of more modifiable risk factors such as uncontrolled hypertension, alcohol, using concomitant drugs like non-steroidal anti-inflammatories or antiplatelet drugs, and also poorly controlled INRs, so patients who still are on warfarin with poor control significantly increases the bleeding risk. And that's why I prefer HASBLED, because there's more modifiable risk factors in there, whereas Orbit is more around previous anemia and past history of bleeds, and actually there's not much you can intervene with around Orbit. I mean, Orbit, from a purist point of view, probably does give you a better bleeding risk score. But the real key message is you never really use the bleeding risk score as a reason not to anticoagulate. For the vast, vast majority of patients, there's still going to be net clinical benefit of anticoagulation in terms of reducing their risk of stroke. And the value of the bleeding score, particularly HASBLED, is what you can do to reduce their bleeding risk. So you've got an even more favourable balance of benefit in favour of stroke prevention. So that's the way to look at the bleeding scores, is not as a reason not to anticoagulate, but what can I do to reduce their bleeding risk? If they're on warfarin and they can be switched to a DOAC, they don't have a contraindication, and then personally I'd be looking to switch them to a DOAC. And again, if they're on non-steroidals, maybe look at other ways of managing their chronic pain and look at their alcohol intake, get their blood pressure under good control. So all you're doing is improving the benefit, the net clinical benefit of anticoagulation. Very small number, their bleeding risk will be very high, whatever you do. And then you have to make a sort of informed decision and discussion with the patient and their relatives if necessary as to where that balance lies. But that'll be a relatively small proportion of patients. The vast majority in net clinical benefit is of anticoagulation. So please don't be put off just by a slightly elevated HASBLED score. Look at what you can do to reduce it. That's the key message.
And talking about rate and rhythm control, and this is something I'm always been a bit confused by, because where does the GP come in and when does they then would refer on to secondary care?
Mm-hmm. Sure. Most of it's around symptoms. So that's the main evidence in terms of getting patients back into sinus rhythm, is around the impact of symptoms on that patient's quality of life, whether it's palpitations or breathlessness and reduced exercise tolerance. So if you've got any sort of concern or worry that the AF is contributing to that, then absolutely I'd have a very low threshold for referring that patient on to cardiology. And again, if they're asymptomatic, so we're just picking them up opportunistically in flu clinic or diabetes clinic, absolutely asymptomatic, then my inkling then is to carry on with permanent atrial fibrillation. The question is always whether or not to get an echo. Not all patients with atrial fibrillation will need an echo by any means. If they're asymptomatic, you're happy to manage them. And again, decisions around stroke prevention and anticoagulants, you don't need an echo for. They're just clinical decisions we can make in general practice. But if you suspect they've got some underlying structural abnormalities, such as a murmur or signs or symptoms of heart failure, then an echo, again, is perfectly reasonable if you think it's going to change your management. Any patient that you think is symptomatic and is going to need onward referral would definitely need an echo just to see what's going on with their ventricles and their atria in particular. If they've got a lot of atrial remodeling and dilatation, then the chances of them maintaining sinus rhythm in the short or even longer term is going to be very small indeed. So that might be helpful in either you or the cardiologist making the decision to manage this as a long-term rate control and just focusing on symptoms and quality of life and stroke prevention. And actually that is the majority of patients will be in that camp. Definitely younger patients, I would definitely refer. So I think depends how you define young these days, because the age is going up, and I've got some very, very fit 70, 80-year-olds, so I wouldn't want to just use a cut-off age. It really is all about biology and how fit people are. But if they're symptomatic, absolutely, I would have a very low threshold to referring them, just asking the question, is cardioversion appropriate here? And there is a window of opportunity. The earlier you do it, in terms of cardioverting them, the more likely you are to be successful. So AF begets AF, so the longer you leave it, the more established it gets. So you need to make that decision relatively early on as to whether you're going to refer them on for further assessment with a view to possible cardioversion.
Okay, so say they have cardioversion, or say they even have catheter ablation, but the AF has gone, for the moment at least. Nice, very clear. They sort of say that's not a reason to stop anticoagulation by itself. Why is it important to continue anticoagulation in certain patients if they haven't got any AF?
Yeah, because they're not curative procedures. There's always a likelihood that AF will recur at some point. So even ablation in the best hands isn't a curative procedure. There's always a risk it'll recur. And I think the general rule of thumb is, again, you'll be driven by their CHADS-VASc score as to their need for anticoagulation. And that's effectively going to be the same post-cardioversion as it was pre-cardioversion. So if they've got diabetes and hypertension, they'll still have that following their ablation or cardioversion. So they still have that increased stroke risk. So it's just mitigating those that do get further recurrence. You're still going to have that thromboembolic stroke risk. That's why I think NICE went for that sort of recommendation. And again, I would agree with that. So often we see atrial fibrillation recurring. It may be 5-6 years down the line, but there is a higher chance of it recurring.
I don't know whether this would force the GP or whether it's the cardiologist of managing the patient's expectations. So, they've gone for catheter ablation and you sort of need to manage their expectation like this isn't a cure.
Absolutely. I couldn't agree more. And as far as I'm aware, that certainly is the case. I think most EP cardiologists and cardioversion are very clear now in terms of counselling their patients around what they're looking to achieve, the incidence of recurrence, and around counselling around long-term anticoagulation, because the cardioversion or the ablation is around symptoms and quality of life, which is very, very important, but that's why you're doing it. You're not doing that to reduce their stroke risk. You're doing it to get their symptoms under control.
Going back to older patients, and so say someone who's living in a nursing home, they'll probably have several comorbidities, they'll be on several medications. The benefits of anticoagulants would still outweigh the risks for those patients.
Yeah, definitely. In this setting, unfortunately, if patients are unfortunate enough to suffer a stroke on the background of atrial fibrillation, they're particularly devastating strokes. So they're not like your little platelet that just fires off and just distally affects part of the distal cerebral circulation. These tend to cause quite proximal occlusions. They tend to be quite large clots. So they really are quite devastating in terms of their sort of functional impairments following the stroke. So again, for the vast majority of patients, again, anticoagulation would be the best strategy. Again, there may be opportunities to deprescribe with other medications, the more frail our patients get. And that's really where we come into our own, I think, as GPs and community sort of doctors, is making those sort of nuanced decisions. And personally, anticoagulation would be one of the last things I would deprescribe. I think there's lots of other medication you would probably look to stop before you stop their anticoagulation, just because they are, particularly in that older 80, 85-year-old group, their stroke risk is very high. It's anything 10, 12% a year. But yes, you're absolutely right. It is all around quality of life and what you're trying to gain. And again, that's where the conversations come in with the patient and their next of kin as to, you certainly would look at the dosing. So I think that's an important caveat to the DOACs. You need to keep on reviewing the dosing based on their renal function and weight and that sort of thing. So if you're going to do one thing, just make sure you're not overdosing the elderly in terms of the dose of DOAC that they're on. So that's something that we've got a fantastic team of clinical pharmacists that we work with. So that's definitely something to keep an eye on, because often their renal function tends to dip off a little bit. So there may be scope to reduce the apixaban dose or edoxaban, whatever you're using. But I'd stop other drugs before the anticoagulants.
Because it's not so much the risk that they'd have a fatal stroke, is that they have an extremely disabling stroke.
Yeah, absolutely. It's the disabling, loss of function, real dependence, going from living independently and mobile and ambulatory to being completely dependent and bedbound. And we've all got patients like that. I mean, less so recently, I must admit, since we've all treating our AF patients much better over the last sort of 10 years or so. But it is devastating when it happens. So anything we can do to prevent that is got to be good.
Just as a final question, what are your take-home messages about the management of AF in primary care?
I think we need to be very proactive and opportunistic, certainly around the detection side of atrial fibrillation. So looking at our chronic disease clinics, our sort of elderly patients, absolutely, whenever you're taking a blood pressure, do palpate their pulse first. Do that manually. And if they've got an irregular pulse, then do a manual blood pressure reading, and then ideally follow it up within that setting, if it's available, getting an ECG done. Once we've confirmed atrial fibrillation, then you need to look at the sort of impact that's having on the patient's quality of life around symptom burden. And decisions around that will then decide whether to go down the cardioversion or rhythm control route. In all patients, we need to assess their stroke risk. Currently using CHADS-VAS2, but do keep an eye on the new guidelines as they evolve in terms of female gender. So stroke prevention is the key intervention with atrial fibrillation. Every patient, we need to know what their stroke thromboembolic risk and manage that accordingly. And then supporting patients post-diagnosis with regular reviews, managing their comorbidities, whether it's their diabetes or their obesity or hypertension. So making sure we're treating all their comorbidities. Atrial fibrillation doesn't happen in isolation. It's just a substrate for other conditions. So we need to make sure we're managing those appropriately in terms of reducing the patient's cardiovascular risk as well as their stroke risk.
Thank you so much for speaking with me today, and thanks to our listeners for joining us. I've been Dawn Liz Powell, speaking to Dr Chris Arden about atrial fibrillation. This episode was produced by Jude Owen. Don't forget, you can claim a CPD certificate for listening to this episode. Simply head over to the website version at mimslearning.co.uk. Join us next week for more clinical insights and fascinating facts.